we had the disease monitoring session, and there were very nice overview talks as well as certain abstracts being presented that covered the gamut of MGUS to smoldering to active myeloma as well as relapse disease. So I'll start with summarizing the abstracts from each of those settings. First, we had an abstract from the iStop-MM study looking at monoclonal gammopathy or monoclonal proteins being identified in patients and the presence of abnormal plasma cells in circulation. And what was interesting about that data set is that we are getting early insights of which monoclonal proteins actually are significant versus not, because there were some transient monoclonal proteins seen where patients did not have an abnormal plasma cells, and those went away. Whereas for true MGUS, there were abnormal plasma cells being observed. The second abstract was looking at immune profiling in the peripheral blood as well as bone marrow microenvironment from the E-PRISM trial that Dr. Gobrial and her group led. It was a multi-institutional study looking at elotuzumab, lenalidomide, dexamethasone in high-risk smoldering myeloma patients, and their group looked at immune profiling compared to normal donors as well as untreated patients. And what they showed was dysfunction across the board in the immune repertoire, and the key finding was how detailed that analysis can actually look, and how the bone marrow and the peripheral blood kind of correlate with each other. They did not draw any conclusions about response or survival outcomes, but I think that's what they will be aspiring to do. Then we had an abstract looking from FORTE trial looking at minimal residual disease either being sustained or early loss. And the most important part from that data set in my mind was that early loss is seen in patients who have 1Q abnormalities, who have circulating tumor cells, and they actually looked at circulating tumor cells at a very low level. And then patients who have 2 or more high-risk karyotypic abnormalities. And the last one was Bruno Paiva's presentation on the sustained MRD negativity time points in Abecma or ide-cel, which is a BCMA-directed CAR T-cell therapy that's FDA approved as well as EU approved for patients with relapsed refractory disease. And sustained MRD negativity at the 3-month mark appeared to correlate the most with the prolonged PFS. But I thought from a practical standpoint, MRD positivity at the 1-month mark, that correlated with very low PFS. So from my perspective, that was probably the most important piece that I took away, that if you are going to check MRD at the 1-month mark, it's not to look at MRD negativity, because you can see hemodilution and patients are very cytopenic at that time. It's more about presence of disease. If you see it, that's not good. So maybe we should be thinking about other strategies for those patients sooner than later.